Please note, most of the case examples used in this video are from actual investigations. Although CDC guidelines provide a standard framework for decision-making in congregate setting contact investigations, the principles and concepts within these guidelines may be interpreted and applied differently within TB programs. Decisions on how to proceed during such investigations are often dependent upon local standards of practice and the expertise of the lead investigators involved. As such, this video will not provide answers to address the universal complexities inherent in many investigations. It is incumbent upon the viewer to be familiar with their local standards of practice, including when to initiate an investigation, the definition and identification of high and low risk contacts, and when to expand testing to low-risk contacts. While congregate sites will always vary in their specific characteristics, the concepts outlined in the examples chosen for this video should be applicable across all types of investigation sites. Conducting the tuberculosis congregate setting contact investigation. An effective contact investigation is an essential component of tuberculosis prevention and elimination. As part of an investigation, a healthcare worker attempts to identify all the high and low-risk contacts named by a patient with confirmed or presumed infectious TB. This identification is based on exposure or medical risk factors. The goal is to refer these contacts for medical evaluation and treatment if appropriate. Because exposure and transmission can occur in settings beyond the household, patients might disclose possible exposures that occurred at a congregate setting. Congregate settings are locations where groups of people meet or gather and share the same airspace for either a limited or extended period of time. Similar to smaller investigations, congregate setting investigations are essential in identifying individuals who may have been exposed to the person with TB and referring those individuals for appropriate medical evaluation. As you might imagine, these investigations can often lead to the identification of a large number of individuals who were potentially exposed. These investigations must therefore be conducted wisely to avoid unnecessary testing of those who are at no risk for transmission. They require a thorough understanding of infectiousness and transmission. They also require skill and professionalism in dealing with site management personnel and sensitive issues such as patient confidentiality. With that in mind, let's look at the key steps that many programs use to ensure successful outcomes when conducting congregate setting contact investigations. Initiating a congregate setting contact investigation. It's important to note that just because you initiate an on-site investigation, that does not automatically mean that you will be identifying contacts for testing. It simply indicates that the setting needs to be assessed to determine whether there was the potential for exposure that would require testing. For the purposes of this video, we'll assume that the need to explore contacts outside the home has already been determined. We will also assume that written permission from the patient to reveal his or her identity to site management has been obtained, in accordance with recommendations from the Centers for Disease Control and Prevention, or CDC. In the event a patient does not consent, it is best to remind the patient that the public's health outweighs individual medical privacy rights. The CDC recommends that all settings where transmission potentially occurred be visited within 5 business days from the time a setting is identified. However, please follow your local standards of practice. The first step is to notify site management of the public health matter. It's best to contact the highest-ranking manager or administrator at the site. The patient may be able to provide the name and contact information. Ideally, this notification should occur within 1 to 2 business days after exposure in the congregate setting has been identified by the patient. A phone call is the preferred method to notify management and to schedule a face-to-face meeting. Unscheduled visits are generally inappropriate. Emails may be ignored or deleted, and traditional mail is too slow, impersonal, and unreliable. Use the initial phone call to begin the process of building trust and rapport with management, the same way you would with patients. During the phone call, it is best to avoid revealing the patient's name or diagnosis, as this risks violating patient confidentiality. Mentioning TB or tuberculosis over the phone could immediately cause anxiety and panic. You also don't know what the person is going to do with that information after the call, or what someone they tell might do. So when you introduce yourself, it's best to keep the conversation general and avoid specifics. You could simply say, "I'm calling from the local health department about an important health matter." If you experience pressure to reveal what the meeting is about, just say, "My health department doesn't allow me to provide details over the phone. I can explain in person." What you say and how you say it can set the tone for your relationship with management. So during this brief introduction, be professional and demonstrate your sensitivity and expertise. Schedule a face-to-face meeting and end the call. The in-person management meeting. The in-person meeting should take place as soon as possible after the initial notification. Have an agenda that follows an orderly and informative discussion, focusing on the purpose of the meeting, the need for patient confidentiality, potential media interest, and any relevant issues surrounding the investigation. It's also important to address the public health responsibility to investigate all potential sites of exposure. Because there are misconceptions surrounding TB, it is wise to provide basic TB information as well. Define the infectious period and its role in the identification of contacts. Explain the health department's role in ensuring treatment adherence when the patient is cleared to return to the site. Next, have a general discussion with management focused on the physical environment of the congregate setting and the patient's relationship to that environment. This is also a good time to ask for a floor plan of the site. Ask about the total number of individuals associated with the setting, including those who are in close proximity to the patient. Describe your health department standards for identifying and testing high and low-risk contacts while stressing the need to avoid unnecessary testing of the worried well. Explain the purpose of initial and post-exposure testing, where testing may take place, and any follow-up testing that may be required. And finally, offer TB education sessions to all members of the site. At the conclusion of the meeting, ask to see the exposure site. This will confirm the information shared by the patient and management. Before we continue, let's take a look at a sample case to get you thinking. Samuel is a 20-year-old U.S.-born male. He had been coughing for 6 months when he was found to have an abnormal X-ray with cavitary disease and positive sputum smears. In April, he was diagnosed with presumed pulmonary TB, which was confirmed with a final culture identification of Mycobacterium tuberculosis. During the TB interview, in accordance with CDC guidelines, you established that the infectious period onset date is August 1st, 3 months prior to onset of cough. For the purpose of a contact investigation, the infectious period can end when the general community is no longer exposed, in this case, when the patient was effectively isolated. However, it is important to note that the biological end to the infectious period occurs with 3 negative sputum smears. The index patient identified 3 household and 2 social high-risk contacts. During the infectious period, he also attended a local university as a full-time undergraduate student, commuting to campus by car. So the exposure period for potential contacts at the university extends from the first day of fall semester classes, September 1st, to March 31st, the last day the patient attended classes. If you were conducting this investigation, what thoughts might you have at this point? Would you be concerned about potential exposure and transmission to students and faculty? If so, how would you proceed with the congregate setting investigation? Delay it pending the results of the household and social contacts? Or initiate a simultaneous congregate setting investigation while the other contacts are being evaluated? There is no right or wrong answer here. How you proceed will be influenced by your local program standards of practice and the availability of resources. In this case, the congregate setting investigation was initiated while the household and social contacts were being evaluated. The management meeting and on-site assessment were conducted with the Dean of Students, Student Health Services, and local health department staff in attendance. The purpose of the meeting was to address the agenda items mentioned earlier and to collect any additional relevant information related to potential exposure of faculty and students. During the management meeting, what specific information would you want to collect from the Dean of Students? Management tells you the university has a total enrollment of 13,462 students. Samuel told you he was enrolled in 11 classes during the entire infectious period, which spanned the fall and spring semesters, and had good attendance. The classes typically met 2 times per week for 1.25 hours, for a total of 2.5 hours per week. Even though Samuel told you what classes he was taking and gave you his schedule, you'll want to confirm the accuracy of the information with the Dean of Students. You'll need the list of students and faculty potentially exposed. You'll also want to ensure that no other possible exposure settings were forgotten. Requesting class rosters will allow you to look for the names of students and faculty who may have shared multiple classes with Samuel during the infectious period. This helps to identify contacts based on the environment and their exposure time. At the conclusion of the meeting, a visit to all classrooms is recommended. The site assessment is critical in determining potential exposure and transmission. In conjunction with or in the absence of a detailed floor plan, making diagrams and hand drawings is a useful way to assess the site. For starters, it helps you to clear the clutter of the environment and focus in on what's important to the investigation. Diagrams can also help you recall a site when you return from the field or, if necessary, at a later date. This sort of visual representation is also useful for decision-making with a supervisor who is not on site with you. In your diagram or drawing, consider your observations of the overall design of the exposure site dimensions expressed in square feet, ceiling height, ventilation type and adequacy. For example, is the air moving or stagnant? What is the air temperature? Are there windows, and if so, do they open? Also note the number and proximity of individuals to the index patient. You may want to consider carrying a pen or pencil and a pad of paper for quick sketching. You don't need to be an artist. A crude drawing will do. With consent from management, photographs may also be helpful. Photos are obviously faster than sketching, but you'll still need a way to make notes about the space and the people who occupy it. If you're using a tablet, you can mark up the photo electronically. If available, a laser measuring tool can be useful as well, although you may need to resort to counting ceiling or floor tiles. Ask management about the patient and their location, responsibilities, and daily activities. In a school or college setting, you'll need to do multiple drawings of various classrooms, labs, the cafeteria, and so forth. Typically in high schools, the classrooms are the same size, 500 to 600 square feet, with the exception of a computer room or science lab. In colleges, most classrooms are similar in size to high school classrooms, with the exception of lecture halls. For each classroom, label the class name, note the number of students, and, if known, where the index patient may have regularly sat. Let's take a look at a few common congregate settings, and then we'll explore the university attended by our index patient, Samuel. Here's a warehouse that's 240,000 square feet, including a break room, with a ceiling height of 75 feet and adequate ventilation. The site employs 21 people full-time. The index patient had been coughing for 2 months. X-ray showed cavitary disease, and she was sputum smear positive 3+ with final culture pending. She was diagnosed with presumed pulmonary TB. During the infectious period, she was assigned multiple tasks, which varied from day to day, but she worked alone and did not make use of the break room. Given the patient's lack of close or prolonged contact with her coworkers, no contacts were identified for testing. The nature of an environment can influence and drive your decision-making. That's why it's so important to conduct an on-site assessment of an identified setting. Consider how your thinking might change, for example, if this same patient worked in a different type of setting. Say, a small garment factory. This factory measures approximately 800 square feet with 10-foot ceilings and questionable ventilation, even though the windows open. Let's say the index patient is part of a staff of 21, which includes a supervisor and 2 part-timers who both work 2 days a week. Even if the staff have assigned seating, the space is very tight. So here, the entire staff might be considered high-risk contacts, since the smaller setting would likely be more conducive to transmission. In this example of a restaurant, the X represents the index patient who was employed as a grill worker. The kitchen area is 210 square feet, with 3 feet between the grill and the back wall. It's stuffy back there. But the area in front of the grill is open, so the wait staff working in front of the grill would have very little exposure, other than when standing by the pickup window waiting for the food. The only people determined to be high-risk contacts who needed to be tested were 3 workers in that grill area. All 3 were non-US born and positive on TST with negative X-ray results and were started on treatment for TB infection. Since all 3 offered verbal history of positive TST, no additional high or low-risk contacts were identified for testing. For comparison, let's say this same patient worked instead in a kitchen for a large catering company with a staff of about 30, working in one open area measuring approximately 850 square feet, with a ceiling height of 12 feet and a ventilation system to the outside. Although the area appears open, the staff co-mingle and cross into one another's space all day as they prepare food, making it difficult to distinguish high and low-risk contacts. Consequently, there may be justification for identifying and testing all 30 employees as high-risk contacts. This is a sketch from an investigation involving a small house of worship. The index patient was coughing 2 months, had non-cavitary disease, was sputum smear positive with final culture pending, and presumed to have pulmonary TB. The patient attended services on Sundays as a member of a 7-person choir. The entire congregation consisted of approximately 35 members who sat randomly throughout the sanctuary's 28 pews. The sanctuary itself measured approximately 2,400 square feet with a 26-foot ceiling. This area is spacious and well ventilated. In this case, only the choir members were identified as high-risk contacts who required testing. All initial and post-exposure tests were IgRA negative. This was a relatively small house of worship. What if the same patient were a member of a larger house of worship? While the more expansive setting would likely be less of a concern for transmission, you might still want to test the choir members. And what if this patient also attended a Bible study class after Sunday services, in the basement, which has inadequate ventilation, with 27 other students and a teacher for an hour each week? Regardless of whether the index patient always gravitated to the same seat, the entire Bible study class would be considered high risk. In this next example, we have a patient who was employed as a part-time online shopper at a large supermarket. The patient had been coughing for 1 month, had non-cavitary disease, and was sputum smear positive with final culture pending. Approximately 3 hours per day were spent shopping in the store, which measured 100,000 square feet with a 20-foot ceiling. The patient spent about 2 hours each day in the computer room and staging area, which measured approximately 2,000 square feet with a 13-foot ceiling. The computer room was spacious, with an adequate supply of fresh air entering through sliding doors to the outdoor customer pickup area. This, coupled with the random scheduling of other part-time coworkers assigned to the computer room, meant that no testing was recommended, aside from one worker who was regarded as a social contact to the index patient. So even though you have a large facility with hundreds of employees and thousands of customers, that doesn't automatically mean you'll have contacts who need to be tested. In this case, the one social contact gave a verbal history of a previous positive TST, but offered no documentation. As a result, the contact was tested and found to be IgRA positive with negative chest X-ray and was offered treatment. Had this same patient worked part-time, say in a small office setting, with a consistent group of colleagues 5 hours a day, it would be reasonable to identify all of his coworkers as high-risk contacts. Sample case, the site assessment. In the case of our college student Samuel, it was critical to visit the classrooms to get a sense of size, layout, and the number of students in each room. The classes ranged in size from 400 to 1,200 square feet, with an average classroom size of 400 to 500 square feet. The ceilings were 10 to 12 feet. During the fall semester, there were several classrooms measuring 400 square feet. These were crowded with inadequate ventilation and windows that did not open. This is a typical classroom: 500 square feet, 27 desks, 18 students, 12-foot ceiling, and windows that don't open. What are your thoughts now that you've seen the classrooms? What else might you want to know? During the initial patient interview, you always want to ask whether there were assigned seats. Typically in college, there aren't, yet people tend to gravitate to the same seat or the same part of the room. It's important to ask the patient where they sat and if they sat next to anyone on a regular basis. In this case, the index patient was unable to provide any relevant information regarding seating arrangements or proximity to students on a regular basis. Identifying high-risk contacts. As mentioned previously, the purpose of an investigation is to identify all potential contacts and medically evaluate those considered to be at risk in order to interrupt the chain of transmission. Current CDC guidelines recommend that congregate setting contacts be characterized as high risk if they've been exposed to a person with presumed or confirmed pulmonary and/or laryngeal TB who was diagnosed based on either a positive smear or cavitary disease. Medical risk factors must also be considered regardless of exposure. You'll also want to make note of any low-risk contacts, keeping this list in reserve for possible expansion of the investigation if you see transmission within the high-risk group. Of course, your on-site assessment may reveal that no exposure occurred with no need for testing. That's because TB is typically transmitted through close, prolonged, intense exposure. It is not usually transmitted through casual exposure, although under certain conditions, transmission can occur through casual exposure. Assessing the probability of transmission during the infectious period involves 3 factors: the infectiousness of the index patient, the environment where the exposure occurred, and the duration and frequency of the exposure. Let's take a closer look at each of these 3 factors. You can determine the infectiousness of the index patient based on their bacteriology or pathology results, whether cavitary disease is present on X-ray, and whether the patient has a recent history of cough or currently has laryngitis. Next, consider the environment where the exposure occurred. This includes the size of the area, quality of the ventilation, and how crowded the setting is. When figuring the length of exposure, factor in both the duration and frequency of exposure throughout the infectious period. For example, the CDC does not recommend routine testing of customers of an establishment such as occasional restaurant patrons. Finally, review the characteristics of the contacts. Consider their age and whether or not they're immunocompromised or have any medical conditions which put them at higher risk for TB infection and progression to TB disease. Also consider elements of their lifestyle, whether they have stable housing or are transient, and if there are substance use issues. The concentric circle model. Some programs use the concentric circle model to help investigators visually designate high and low risk contacts. In this model, the index patient is in the center. The next circle out, representing high risk contacts, are those who have had close, prolonged exposure with the index patient during the infectious period. Typically, TB transmission is found in this immediate circle around the index patient. Each circle out represents those with less exposure and therefore a theoretical lower risk of becoming infected. However, those with limited exposure who may present with high-risk medical conditions should also be considered high-risk contacts. As you collect information and formulate the list of contacts, you can either put their names in the circles if you have enough room, or assign each contact a number and place these numbers in the circles. If you decide you need to expand the investigation, the concentric circles help to quickly identify who should be tested next. The visual nature of the diagram can also be useful in explaining to site management why initial testing is limited to high-risk contacts. Sample case: who should be tested? Returning to Samuel, the class rosters identified a total of 265 students and 10 faculty members, for a total of 275 individuals who had potentially been exposed. Cross-referencing the rosters revealed several students and 1 faculty member who were in more than one class with the index patient. During the fall and spring semesters, there was a range of exposure hours, from 20 to 108 classroom hours per student. No students overlapped both the fall and spring semesters. Considering classroom characteristics and the range of exposure hours, you could then develop a list of students and faculty who had the most exposure and configure a concentric circle. In this case, those having 80 to 108 hours of exposure were identified as being high risk. This equated to 19 students and 1 faculty member, who were all from the 16-week fall semester. One could argue that the spring semester contacts were at higher risk because the patient may have been more contagious just before his diagnosis. Again, this is where your own judgment comes into play. After all, the patient was also infectious and coughing throughout the fall semester. Notifying and arranging for testing. The time, date, and place for testing all high-risk contacts should be scheduled in advance in a time frame consistent with your local health department standards of practice. It's recommended that all individuals associated with an exposure site be notified in writing. This is most often done by Congregate site management with assistance from the TB program. It is best not to provide these letters on a Friday, as no one may be available over a weekend to answer questions. A general information letter is typically sent out to inform everyone of a potential exposure. This transparency helps prevent the spread of rumors and misinformation. A more specific notification letter is sent to those contacts who are required to be tested. Depending on the type of setting, this letter may include the time, date, and location for testing, with the option to get tested by a primary care provider or local health department. It also mentions the importance of testing in a timely manner. If the patient chooses their primary care provider, you will need to obtain and document the test result. In both the general information letter and the specific notification letter is an invitation for everyone to attend the education session. The education session is a critical component of the congregate setting contact investigation. The goals of this session are to increase TB knowledge, alleviate fears, reduce anxiety, dispel TB myths, and address issues of stigma related to TB. The education session provides an opportunity for everyone associated with the setting to have their questions answered and become better informed. Ideally, this session should be held prior to any scheduled testing. To reduce anxiety, it is also beneficial to schedule the educational session and testing as close together as possible. Visuals in the form of slides and printed educational handouts can reinforce key messages. Examples of educational content can be found on the CDC's website at www.cdc.gov/TB. Important topics to discuss during the education session include the difference between TB infection and TB disease, symptoms of TB disease, how TB is and is not transmitted, what constitutes an exposure, the importance of contact investigations, diagnostic testing for TB infection and TB disease, the need for initial and post-exposure testing, treatment for TB infection and TB disease, the importance of adherence to treatment, and directly observed therapy. These sessions should be conducted using plain language without the use of medical terminology. You'll want to allow time for discussion and encourage participants to ask questions as they arise. This can also help you gauge the audience's understanding. If you are not a clinician or healthcare provider, it's recommended to have a physician or nurse with you for these sessions. They lend credibility and can address any clinical questions. Most importantly, emphasize the role of the TB program in maintaining patient confidentiality. Under no circumstances should there be any reference to the identity of the patient nor to the individuals being tested. If you're asked, however, information can be shared regarding how those requiring testing are identified and notified. End the session by sharing your contact information with the group in case they have additional questions or concerns. After reviewing the high-risk contacts test results, you'll need to decide whether to expand the investigation. According to the CDC, if no transmission is evident in the high-risk contacts, the investigation should not be expanded to lower-risk contacts. If there is evidence of recent transmission, you can consider expanding the investigation to low-risk contacts. Evidence of recent transmission includes identification of secondary cases, or a high rate of positive TST or IGRA results that meet or exceed your TB program's recommendations, or positive TST or IGRA results in children under 5 years of age, or Transmission confirmed by documented TST or IGRA conversions among the high-risk contacts. Again, thinking in terms of the concentric circle model, you would then move out to the group of low-risk contacts. With a congregate setting, there is always the potential that there may be a large number of contacts. The goal is to identify those most likely to have been exposed. In certain congregate setting investigations, high and low-risk categorization may be difficult to determine. In those cases, you may choose to err on the side of caution, testing more people than you would otherwise prefer. You may consider closing the investigation upon completion of the initial and post-exposure testing and medical evaluations of all identified contacts. Follow your local health department's standards of practice for closing and evaluating a contact investigation. Sample case, assessing the results. Returning one last time to the case of our college student Samuel, if you'll recall, we had identified a total of 25 high-risk contacts, 3 household contacts, 2 social contacts, and 20 contacts at the university. Of the 3 household contacts, 2 were IGRA positive with negative X-rays and were started on treatment for latent TB infection. The 2 social contacts were both IGRA negative on initial and post-exposure testing. Of the 20 school contacts, 7 were IGRA negative on initial and post-exposure testing. 10 had a TST of 0 mm on initial and post-exposure testing. 1 had initial TST of 13 mm and was started on treatment for TB infection. 1 had a prior documented positive TST result and had previously completed treatment for TB infection. This contact was asymptomatic and discharged from the clinic, and 1 contact could not be located and had left no forwarding address after leaving school. Applying these findings to the concentric circle model, the person who had the most exposure was IGRA negative, while 1 student contact who had 80 hours of exposure was IGRA positive. This was a non-US born contact. There was suspicion that this person was likely positive prior to exposure to the patient. So from the original list of 275 potential university contacts, just 18 were tested and only 1 was positive, representing a 5.5% transmission rate. Some programs may have elected to cast a wide net and test all 275 contacts. This could potentially reveal additional positives that may represent remote as opposed to recent infection. The advantage of the concentric circle model is that it allows you to start small with the option to expand based on the results you're seeing. In Samuel's case, the investigation was closed with no expansion of the concentric circle. A congregate setting contact investigation is not without its challenges. While some contact investigations are considered routine, uncomplicated, and uneventful, others are complex, requiring careful thought. Regardless of the size of the investigation, however, it should always proceed with comprehensive planning. Depending on the setting, there are a host of challenges that may be associated with these types of investigations, including a very large number of identified contacts, vague information for determining contact priorities, incomplete identification and locating information for contacts, maintaining patient confidentiality, collaborating with officials who are unfamiliar with TB, and media coverage. The way these challenges are addressed brings us full circle to the skill set, experience, and professionalism of the TB program staff. Hopefully, this educational video has helped you to feel better prepared to conduct an effective congregate setting contact investigation. For further information on contact investigations, visit globaltb.njms.rutgers.edu.